Welcome to another the with HRN. My name is Alex Bridge-Shewan. Of course, I'm one of the experts in pulmonary rehabilitation. I'm a respiratory trade. I'm the executive officer and director for the clinical director for HRN itself, where we provide pulmonary and cardiac rehabilitation. So if you haven't done so, please like and subscribe on our channel, as you get a lot of informative information in regards to lung health, lung anatomy, physiology, and a lot of other things. Also, if you would like, you can please also comment or ask questions on the comment section of this live feed, or even after, really, but during the live feed, and I'll be happy to address any types of questions, comments, concerns, anything like that as we go along. Our topics that I want to go over is the difference between different COPDs, okay? Just kind of understanding, in my classes, like in my today's class at 1 o'clock, we're doing a walk test. And a 6-minute walk test, why is it 6 minutes? Does anybody know the reason why it's 6 minutes? Why isn't it 10 minutes? Why isn't it just a simple number, like, 10, 5? Why is it 6 minutes? Why is it a 6-minute walk? I get questions like that sometimes. Not a lot, but I get questions sometimes. And the reason for a 6-minute walk test is to see how well the body functions through chemistry, through stats, data, vitals, things like that. And we look at blood pressures. We look at subjective and objective measurements. So we look at blood pressures. We look at how the person's feeling out of breath, how high their heart rate is during the exercise, during the first, before they started, to 3 minutes in, to after 6 minutes, and we look at, we're looking at blood pressures to make sure that the pressures in the blood, or the blood pressure, the systemic pressures are good for exercise. And 6 minutes is all we need. So when we're doing a 6-minute walk test for somebody, or just in general, when we're doing a 6-minute walk test, we're not trying to see how far the person can walk per se. We're looking at how the body reacts to 6 minutes of continuous exercise, and in this case, walking. And on a walk test, a lot of people don't like walk tests because they're afraid of the results. But unfortunately, that's something that we do have to look at. As we're looking at results, we're looking at how somebody is, functioning, how their oxygen is doing, how their CO2 is doing. So there's a lot of different data points that we take and observe when we're doing a 6-minute walk test. But anyways, if you have questions about a 6-minute walk test and anything like that, please don't be shy and go ahead and write in the comment section. And I see there's a lot of people watching me right now, so hello to everyone there. And like I said, comment section, you can write up any types of questions you may have. The difference is, so we have 5 different types of COPDs. 5 different types, okay? So when somebody asks, what type of lung disease do you have, and they say COPD, well, that doesn't give us a lot of information besides, okay, you have an obstructive disease. Okay, but what type is it? Because each different type, there's 5 of them, each different type, kind of has its own type of abnormality, and that's really what distinguishes each disease classifications. Okay, so for classifications, let's say when somebody says COPD, they generally mean emphysema and chronic bronchitis. Okay, but understand those words verbatim. Chronic bronchitis. So bronchitis itself, like acute bronchitis, is not COPD. It has to be chronic. Well, I had this cough for a very long time, or I'm wheezing for a very long time. I said, well, how long have you been wheezing for? I've been wheezing for a few days. That's not chronic, unfortunately. That doesn't qualify as chronic. Chronic is a long term. Okay, we're looking at, 6 months. We're looking at a long duration of these symptoms. So, so the 5 types of COPDs, besides the chronic bronchitis and emphysema, and I'll mention all of them. There's 5 types. We have cystic fibrosis, bronchiectasis, okay? You have the later descent of asthma, so it's not the beginning of asthma, it's when asthma is becoming uncontrollable, okay? It's chronically that way, it's not being managed, so it turns into an obstruction itself. Then, of course, we have emphysema and we have chronic bronchitis, okay? So I'm going to go over emphysema really quick. All right, I'm going to bring up emphysema. So when we find, let me bring the board up here because this would make it a little easier. So I'm going to pull this board right here, just so we can kind of view it. All right, a little better. All right, let me make sure the glare is not there as much. There we go, we'll do that. Okay, all right. I'm wearing sweats because I'm working out with my team, and so we're doing a lot of healthy activities over here at HRN, and we're getting wrapped up for good health for spring and summer. Of course, spring's already here now. Anyways, so we're looking at emphysema, okay? So when we look at emphysema, let's say this is an alveolar sac, okay? Okay, so this is an alveolar sac. All right, now it's a little further up. Don't worry. I'm going to kind of pretend to blow it up a little bit. So we're going to take a small segment and show you a larger version. So this represents one alveoli. This is one alveoli from that alveolar sac. Okay, the alveoli is meant to transport gases. Okay, they're meant to transport gases, and what I mean by that, they're semi-impermeable, meaning they only allows certain gases like CO2 to escape and oxygen to come into the blood itself. And right here, we can easily understand that that's what surrounds the alveolar sac are a lot of capillaries. Okay, the membrane, the outer membrane, is semi-impermeable. It doesn't allow a lot of things to go through it, but it does allow gases to transport past these membranes. Okay, so when I breathe in, air comes in, okay, comes in into the alveoli, comes out. So this is just normal. All right, this is just normal. There's nothing wrong with this. When we have emphysema, this is the problem with emphysema, is let me kind of let you understand it this way. Let me let you understand it this way. You have a phagocytotic cell, a white blood cell, that stays dormant. Now I'll pull these guys out so it's not confusing with all the writing. So you have white blood cells. Okay, what stays on the edges also are 2 different types of cells. We have the alpha 1 okay, alpha 1, and then we have the white blood cells, okay, which actually secrete a enzyme called trypsin. Sorry, I think I misspelled that, but it's trypsin. Okay, so the trypsin is an acid. Okay, it's an acid. So when something enters, so let's say a particle, let's say it was pollen. Okay, let's say it was pollen. Let's just say whatever it was, comes in and it's foreign and the body doesn't like it. It's not a gas. So the white blood cells will actually secrete trypsin to kill what could be potentially hazardous to us and kill these. Okay? So I'm a white blood cell. I'm in an alveoli. Just pretend I'm in an alveoli. I'm a white blood cell. All right? And let's say a little pollen comes in. All right, well, that's not that big of a deal, but just in case, I'm going to squirt some trypsin. All right, trypsin. All right, so I'm secreting acid. All right, secreting. I'm shooting out acid. Okay, it's not like Aliens with Sigourney Weaver or something like that where it's an alien and spits out acid or something like that. This is just the general sense it does secrete trypsin, and that is an acid. Okay, so I'm white blood cell. I'm secreting trypsin. I'm like, all right, so this comes in. All right, a little trypsin there. Okay, all right. So what happens to the trypsin? What happens? Because if I leave the trypsin in there and it doesn't get not dissolved, but it doesn't get neutralized. What happens? Well, just like any acid, it'll start eating away from the walls. Okay. It'll start eating away from the walls. Here's another alveoli right there. First, there was an alveoli right there, but the trypsin ate around that wall. Okay. All right. So what would happen is the trypsin could actually eat through the wall. All right. What neutralizes the trypsin? The alpha 1s. These neutralize it. So when trypsin comes out, okay, the alpha 1 will release a base to neutralize it. Like if you take acid, like if there's hydrochloric acid and you add in bicarbonate, HC, it's HCO negative 3. Okay, if you put in, like, let's say baking soda into acid, or even milk into acid, it forms a base and neutralizes the acid. Okay, like if you had a pool or maybe a hot tub or something, and let's say you kept the temperature exactly, let's say 102 degrees, 103, 102 degrees, with all the heat, and of course any foreign body without any chlorine, it will actually, the water itself could actually form, and the pH could actually start dropping quite a bit. And if the pH drops, it becomes more acidic. So I experienced that once where there was a hot tub at a place, at a hotel. I went into the hot tub and they weren't managing it. I went inside the hot tub and I felt all this tingling sensation, and my skin felt very slimy. The surface of my epithelial tissue felt very slimy. And I realized, from me being a medical professional, that this is acidic. This is very acidic. Okay, I don't know what the pH balance was, but I went out and I told them, and they shut down the hot tub. So, anyways, if there was acid in there, like if the water was very acidic, I can add baking soda to neutralize the acid and bring the pH back up. Okay, not bring it down, but bringing it back up. All right, and that will neutralize the acid, making it neutral, where it's around 7.45, 7.35 neutral. Though it's not acidic, it's not alkalinic. Okay. Anyways, the alpha 1s release a base like a baking soda, but it's not powder. It's a liquid. It releases a base to neutralize the acid, because if it doesn't neutralize the acid will start eating away from the alveolar walls. And then you have these big, huge holes. Okay, that's what emphysema is. Now, can somebody have, I want to see if anybody knows this, since there's a lot of people watching me right now. Can somebody have end-stage COPD in their teens? They're not even 20 yet. Can they have end-stage COPD in their teens? Yes or no? What do you guys think? I'll wait a couple seconds for somebody to write up an answer. Okay, and don't worry if you get it wrong. Don't worry about it. But let me wait before I give the answer here. I'm going to wait just a little bit. If anybody wants to answer, go ahead and write in the comment section. Okay. All right. The answer is, I can't wait that long. The answer is yes, the person can have end-stage COPD. The reason why is something called antitrypsin deficiency syndrome. It's where there's not enough alphas. Okay, there's not enough alphas, and these are secreting trypsin. And let's say there was smoke, and let's say I'm a white blood cell, I'm secreting trypsin. Okay, and there's let's say smoke inhalation. Well, I'm going to overreact because I know that's very bad. Okay, a little bit of pollen, I only secrete a little bit. A little bit of something that's pretty common, I'm only going to secrete a little bit of trypsin because I know what that is, right? That's what the white blood cell's thinking, in a sense, even though they don't really have eyes, they can't see it, they sense it. All right. So if I'm secreting too much trypsin because smoke inhalation, but these alpha 1s, which I erased, these alpha 1s are very little, they're not a lot of them in there. Well, these can only secrete base not as often as trypsin. Trypsin can secrete acid quickly and it has a lot of it. These can only secrete a little bit at a time. All right? So if these overreact and there's not enough alphas, or the alpha is not secreting as much base, well, of course, the acid is going to eat away from the wall, and of course, we're going to have a very large hole. And that's what emphysema is, the destruction of the alveoli. Okay? So if somebody has and I've seen patients like this. The youngest I've seen was 16 years old. 16 years old. Person said they get very winded very quickly. It was actually a GNA that worked in a healthcare facility, nursing home. And I was at a skilled nursing facility and rehab center. I was director there for 10 years. And this person just comes up and says, hey, Alex, I have this big problem. For some reason, I'm getting out of breath very quickly. My heart rate spikes very high. And, I don't know what's going on, but I can't seem to do a lot. I can't seem to walk very far because I get my breathing gets so labored. And that's a big problem. And I was like, huh. I said, well, you don't seem like around that age. Do you smoke cigarettes or anything? And she says, no, I don't. I mean, occasionally, but I don't really smoke anything. I said, okay, all right. I said, have you went to a doctor? He says, well, when I was very young. And I was like, young? You're already young. You're 16 years old. But when's the last time you've seen a doctor? And he's like, well, I go to my primary, often, and I mention this, but nothing was really done. What the doctor should have done, of course, if they suspected this, and some doctors don't know that testing alpha-1 antitrypsin deficiency syndrome is very important, because now this person that's 16 years old has end-stage COPD. All this person needed was a certain medication to be given to basically react as an alpha-1. So they'll actually, take a certain medication that their doctor would give them to stop the ongoing crisis of causing the person's emphysema to get worse, or the lung disease to get worse. Okay, so it's being managed, right? Remember, I am I'm pro medication, but I like to look at things without the use of medications. But in this case, I'm going to be very pro with that medication because that medication will stop the progression. Okay, and this medication will save this person's life. That's very important, of course. Okay, so emphysema is what? The destruction of the alveoli. So let's pretend that this screen right here represents like I'm inside an alveoli. So this screen right here represents an alveoli. Let's just pretend it's round, but this is rectangular. So, smoke comes in, I'm going to overreact. If a little, something that's very common like dust particles, I might secrete a little trypsin. Okay, my roommate, if you will, which is an alpha-1, will neutralize the acid. Okay, and it can keep up with that, unless I have no alpha-1s, and of course I'll start getting lung disease, very severe lung disease, very quickly at a young age. All right, so let's just pretend I don't have alpha-1 antitrypsin deficiency syndrome. Let's just say I'm just a normal person, okay? And anyways, so little pollen, little dust comes in. All right, well, I'm going to squirt a little trypsin there. Not a big deal. Okay, put that right there. All right, it's not a big deal. I don't want my home to die. I live in this home. You know, I'm a white blood cell, right? I live in this home. This is what I don't want this destroyed, you know? I don't want my home to destroyed. So I'm going to skirt this trypsin, you know? My roommate will neutralize that trypsin. So it doesn't eat my home away, you know, the walls of my home away. Anyways, smoke inhalation comes in now. Let's say it was smoke inhalation, let's say it was pollution, let's say it was household cleaners, let's say it was something very bad for my body, you know, especially for my lungs, but really bad for my body. I'm going to overreact. I'm not going to squirt a little bit of trypsin. I'm going to squirt a lot of trypsin. Boom, 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 boom. Okay? My roommate can't keep up. Can't keep up. Can't secrete as much base to neutralize that acid. And I can't hear that my alpha 1, even though it doesn't talk to each other that way, I can't hear that it can't keep up. It's probably yelling at me, hey, stop it, you're killing us, you know. And the acid will actually also kill the alpha 1s. Okay, it will kill the alpha 1s because it's too much acid. All right, that is emphysema. Okay, the destruction of alveoli, it's caused by the white blood cells secreting trypsin to defend the body from invading particles going into my bloodstream. That's its main, it's a very specific job. Okay, so that's emphysema. So the obstruction in it can be caused by, and let me erase this so we can look at this a little more without so much distortion with all this writing. Okay. Like I said, if you have questions or anything, please don't hesitate to write in the comments section. I'll be happy to address any types of questions. All right. So here's an alveolar sac again. All right. Here's my airway, which is a bronchiole. All right. So air comes in. It's not oxygen. It's air. Remember what air is. We have xenon gas. Some people pronounce it xenon gas. You have nitrogen. You have helium in the upper atmosphere. You have a lot of different gases. You have oxygen, which is about 20.95 millimeters of mercury of pressure. We just round up and say 21% of oxygen in the air. So there's only 21%. The majority is above 70% is nitrogen. Okay? And that supplies what? Pressure. It's an inert gas, meaning it comes in and comes out. All right? It supplies pressure. So anyways, air comes in, okay, and the oxygen in the air gets transported through these little capillaries that surround the alveoli. Okay. The air comes in, the oxygen gets pulled out of the air, because remember, those membranes are semi-impermeable. They won't allow all the gases. They only bring in certain gases in. You know, they won't allow a lot of other things to come in to the blood itself because they want to stay alive. So, anyways, with emphysema, we have the destruction of the alveoli, which is just a big, huge hole, and there could be many of them. Okay, there could be many of them. Basically, you can fit about in that little bit of space. Can you see that? That little bit of space between my two indexes and my two thumbs? That space, you can fit probably about 300,000 alveoli in there. They're very, very, very small. Very, very small. Okay, you take a look at a lung, it's very hard to see an alveoli with the naked eye. You need a microscope. You know, but they're very, very, very small. So what happens if I take away the walls? Well, this alveoli can either enlarge, because there are not a lot of cell walls holding the wall up anymore. And of course, we might have a deflated alveoli, or we might have hyperinflated, because there's no connective tissue, there's no tissue keeping it smaller, so there's nothing holding it to prevent it from growing out really, really large. So you have this big, huge hole. And if I take a look at a lung, You can see this on this lung right here. See that? The holes? These holes? Those big gaps in there? That's emphysema. That's what emphysema is. Okay? Remember, it's the destruction of the alveoli. So where's the obstruction at now? Well, because of all this destruction and all this, messing, my airway's all messed up now. Well, this can cause the airways to be well inflamed. And somewhere, like here, or maybe right here, is a pinch. It's almost like a check valve in plumbing, It's almost like a check valve where the lung parenchyma will open up, because how do we open up our lungs? The muscles do that, right? And those muscles are the diaphragm and the muscles in between the ribs, which are the intercostal muscles, okay? So they'll pull open to get air in. So with COPD, it's very easy to breathe in, actually, unless the lung muscles are very weak. So it's easy to breathe in, but to exhale, the muscles relax, and the lung parenchyma that is made out of a collagen fiber called elasticin, that elasticin, which all that means is that pink tissue is just very stretchy, like a balloon. Well, because of the inflammation, and because of probably somewhere around the alveoli where it was destroyed, air comes in easy, but it's having a hard time coming out. Now, it will come out, but it's just going to come out very slowly. All right? It's just going to come out very slowly because somewhere, like I said, here or here, there's a spot where it's pinching shut, and it's not allowing air to come or bypass through that. Okay? That's what emphysema is. And that's what COPD is, where you breathe in a gallon of air, but you're only really getting rid of maybe half a gallon of air, maybe a quarter, maybe 3/4, depending on the severity of the lung disease itself. Okay? The severity of the lung disease. Now, why is, when I held up this lung here, remember, write in the comment section, guys. Don't be shy. I see there's a lot of people. Just write in the comment section. Why is the alveoli, the emphysema, is found mostly on the top, but not so much on the bottom? We have some inflammation here, as you can see that red spot. But why is most, or the majority of the emphysema is found on the top, the apex of the lungs, and not necessarily on the bottom as much? Why is that? Because when you breathe, when anybody breathes, some people don't have enough muscle strength to open up all the lung volume, to open up all the lung. Okay? As you can see, there's these lines. Can you see that? These lines right here, they're called fissures. Okay? These lines right here, they're called fissures. So I can pull and separate this lung, this part, and I can separate them. Okay? And that's how the lungs actually are. So the top part of the lungs, which are the apex, it's almost like a triangle. So if I was to draw a triangle here, well, the top part of the lungs, okay, or the apex of the lungs, of course, I know how a lung looks, but anyways, the top part of the lungs, it's like a triangle in a sense, there's a little bit of fibers here, there's a little bit of tissue here, because it's not as much as the basal areas. We have the medial, and we have the basal areas, and we have the apex, or the top part of the lung. Well, down here, there's a lot of tissue, okay? Meaning it's going to take more strength need more muscle to pull open those bottoms than the ones on the top. The amount of strength you need to open up the tops on average, this is not for each and every person, it's on average depending on their disease, is about 3 to 4 pounds of muscle needed to open up the top part of the lungs. The middle is about 4 to 8 pounds requirements. Do you understand what I mean by that? What I mean by that? Does anybody understand what I mean by that? So that's the muscle requirement to open up to satisfy a full deep breath, to get enough air inside. I need enough muscle. How much muscle do I need to lift 15 pounds? I need enough muscle. My muscles have to be strong enough to lift 15 pounds, right? But if I can't lift 15 pounds, all right, which would be very bad, but if I couldn't lift 15 pounds, all right, then I'm not going to probably lift it all the way, or I'm going to lift it some, but not all. Okay, so every muscle kind of works the exact same way. If it's not strong enough, bottom here, how many pounds do you think that needs? About 12 pounds. So is it easier to breathe shallow than it is to breathe deep? Yes. It is easier to breathe shallow than deep. That's why a lot of people just result in breathing shallow, and they're like, hey, I have severe lung disease. I'm having all these problems, and I said, okay, well, use your incentive spirometer. Let me take a look at your incentive spirometer measurements, and they're at 1,000 milliliters, and they should be way above that, right? They should be way above that. So that just means that the person's muscles aren't strong enough to get any more air into the lungs. Fully capable, but the muscles aren't strong enough. Okay, so what does that mean in regards to emphysema? Well, when somebody doesn't exercise a lot, okay, if this was an exercise like an athlete, I would find, and let's say they smoke too. Let's say they smoke, they have, they're around a lot of pollution, they vape or something like that, but they exercise nearly every single day, and I mean good exercise, like 30 minutes on a treadmill or something, and or just running on a track. Well, I would find the lung disease probably throughout the whole lung, because that person, their lung muscles are strong enough to open up all volumes. Okay. But for somebody who has emphysema, why is the emphysema usually found on the tops? Because that's what the person can expose. The reason why it's not so much on the bottom as much for somebody who's a non-athlete, and I shouldn't say athlete in a sense, but it depends on the athleticism. Like if it's swimming, jogging, running, marathon running, I would expect high volumes. I would definitely expect rock climbers, I would expect high volumes. But let's say somebody was bowling, not putting down any bowlers because I like to bowl too, but let's say it was a lot of somebody who's bowling. Well, that might not be enough exercise for that athlete per se, to get a bigger volume in them, because they're pretty much almost stationary a little bit. They're not jogging. I don't see a lot of bowlers running 10 5Ks or something like that, or running for 10 miles a day. I don't see that. I might be wrong on that, but I don't see that very often, because I see a lot of bowlers a little bit thicker on their gut, some of them, and they don't exercise as much, but still considered an athlete. Anyways, the top part of the lungs are what's being exposed, because when lungs inflate, first it puffs up a little bit, okay? First it puffs up, then the top opens up, okay? So it's top first, middle second, bottom last. So in unison, it's like, just by looking at, you can look at it, well, if you can look at an animated breathing through X-ray, they have devices like that, where you can actually see the lungs moving and the muscles moving and blood moving through an X-ray. It's not a picture, it's a video. Do you understand? So if I'm only inhaling with breathing shallow and I'm smoking cigarettes or doing something like that, I'm only going to expose the top. So the disease mostly would be found on the top and not so much the bottom, because I don't have enough muscle to open them up to expose them to get them diseased, in a sense. Does that make sense? So why is most lung disease found, like emphysema, found mostly on the top? Because of that. Now let's take non-emphysema. Let's take chronic bronchitis alone. No emphysema. Let's take bronchiectasis. That disease is found everywhere. Okay? Like bronchiectasis, let's take cystic fibrosis. That's a hereditary disease. That's not due to smoking cigarettes or something, That's due to an abnormality when I was born causing a problem, okay? That lung disease can be found throughout the whole lung, throughout the whole lobes itself. So each disease is different, of course. That's why they're classified with their name to indicate what kind of disease and what type of problem that person has. All right, so if I have lung disease, what type of lung disease do I have? Now, what's the difference between obstructive lung disease? What's the difference between obstructive and restrictive? Does anybody know? What's the difference between obstructive and restrictive? Don't give me the same answer that is entailed in the question. Don't give me an answer that is like, well, one's obstructive, one's restricted. Don't give me that. What is the difference? Like, why is it so different? It's still lung disease. And what is disease? I hate using the word disease, but it is accurate because by definition, if you just look at a dictionary, disease is an abnormality in the body. So if I have lung disease, there's an abnormality in my lungs. If I have heart disease, there's an abnormality in my heart. If I have, whatever. It's just disease by definition is an abnormality in the lungs. So if somebody can't breathe in very deep, is that still considered disease? Yes, that is of course considered, because it's not reacting, because that's not reacting the right way. Okay, that's not reacting the right way. It's not reacting the way it should be reacting, right? So, okay, now, that being said, the difference between restrictive, and it might feel like obstructive, the difference between restrictive lung disease is what? It's being restricted, right? So there's a lot of fibrotic tissue, okay? A common misconception is lungs don't heal. I don't know where somebody got that information, and they should be, their degree or their whatever they got, certification should be revoked, because that makes zero sense. If the lungs don't heal, why do you have scarring? It's just common sense. If my lungs are bleeding, okay, because of a puncture, or maybe a foreign body, or maybe there was a chest trauma, okay, if I'm bleeding and the platelets are coming out and it's healing up, why would somebody think lungs don't heal? That makes no sense. Now, let's say I have severe emphysema. Is that going to heal? No, that won't heal. But as far as do lungs heal? Yes. But if I cut myself, let's say, because yesterday I used a mandolin for when I was cooking last night, I was using a mandolin. Does anybody know what a mandolin is? It's not a musical instrument. There is a mandolin called which is a musical instrument, but in this case, it's basically it's a yay long device. Has a very extremely sharp blade, which I found out yesterday. A very sharp blade, and it has a guard, and you take your vegetables and fruits, vegetables, and you slice them. Cut them very, very thin. Okay. I was using that yesterday, and of course I cut myself open, and on my thumb. Not a big deal. I don't need to show you, but I cut myself open, and it bled for a very, very long time. And I mean a very long time. It bled for a very long time. Yeah, slicer, very good. It's a type of slicer. So when I was cooking last night, and I don't know if anybody knows, I'm a certified chef. So I've went to the London Culinary College in London to become a chef. And I take a lot of courses. I try to educate myself all the time because I love education. So anyways, besides that, because I'm probably going to start getting hungry in a little bit, besides just the slicer itself, like the mandolin, everything has an instruction. Well, I was too foolish. I don't know why I did it, but I just picked up the mandolin, and I just took the vegetables, and I just started pulling them down without the guard, and of course I sliced myself open, right? My finger was bleeding for quite some time, and the executive chef over there, which was Zooming with me because we were braising lamb, and he wanted to see me do a tenderloin, and anyways, he wanted me to do different things. Well, I cut myself, and of course the executive chef said, "You're not supposed to do that." And I said, "Well, of course I'm not supposed to do that. That was just a foolish thing," thinking that, oh, I'm not going to cut myself. What a foolish thing. Anyways, as I digress. In regards to restrictive lung disease, there is a lot of fibers, right? So if I cut myself, all right, I'm going to have a scar. Am I right or wrong? Okay, did it heal? Yes, that side healed, but I'm left with a scar. I'm left with a scar. So when I have fibrotic tissues, okay, it could be from pneumonia, it could be from, injury, it could be from, if I have a lot of scarring, well, that's going to solidify, not making my lungs very compliant, meaning not easy to breathe in, not easy to breathe out type of thing, because it's going to mean I need more effort to breathe now, right? And as the lungs get more solidified, the shallower I breathe because the muscles aren't strong enough to open those up. If I keep that going, then of course I'm going to wind up with acute on chronic respiratory failure or something worse. I'm going to wind up with a heart attack, and I'll wind up with something else. But the problem is I'm going to die from complications of COPD. I brought this up because a lot of doctors, I don't know why they don't bring this up with their patients. People don't necessarily die from COPD. They die from complications of COPD. So somebody was like, how much time do I have left in this world? I have COPD. Well, if you, what have you been doing to exercise? Well, it's like, I haven't been doing anything because my doctor says that I have end stage. I said, well, you're just going to keep getting worse until your lungs solidify, or, lack of oxygen in the body, okay, cyanotic, right? Meaning not enough oxygen, hypercapnia, which is a heightening of CO2, okay, I'm going to die from complications of that because of the result from having my lung disease, okay? You don't necessarily die from COPD, you die from complications of COPD, okay? COPD is a disease, but it's not a contagious disease, okay? It's non-contagious, all right? Like cancer, it's non-contagious, but the abnormalities of these the squamous epithelial, columnar epithelial tissues. There's a lot of different tissues, basically. But anyways, these tissues, if I start growing masses in them, because my body's producing, it's just an overabundance of a certain mass, and I start getting these big masses, well, I'm not going to transport it to somebody else, right? So I hate to say disease because it sounds like it's something contagious. Hey, I have a disease, Oh, I'm going to step away from you because I don't want to catch it. Well, you're not going to catch it because it's not that type of disease, So when we use, verbs to decipher action or nouns to decipher a person, place, or thing or something, we just have to understand that these words should be taken literally. But a lot of doctors don't understand that, and a lot of them don't understand that somebody has an increase in their lung functions. When somebody gets an increase in their lung functions, what does that mean? They're getting better, okay? They're getting better. So when in the world, if you're improving yourself, okay, this is improvement, this is not improvement. Okay, if you're improving yourself, when are you getting worse? It's not rocket science. If you're improving, when are you getting worse? When are you getting worse? Because if you just keep not doing anything and you just want to talk about your problems, pulmonary rehab is not psychology. Okay, it's not like you're meeting with a psychologist. You have complications that are going to be more complicated if you don't do something about it. So a lot of doctors give you medications, right? All right, let's reduce the inflammation, see if that works. But if you don't exercise, if you don't do any types of bronchial hygiene, if you don't do just simple basic things to help your body out, proper nutrition, weight management, looking at the exercise in general, as far as when would this exercise be more beneficial, is it 1 minute in the exercise? Like if I was going to start jogging, when does it become more beneficial to me? I get that question a lot. When does that become more beneficial to me? Well, it becomes more beneficial if you exercise for more than what? 15 minutes, okay? Technically, it's more like 10 minutes, but if you exercise for 10 minutes, it's a good startup, it's a good start. But if you at least reach 25 minutes on an exercise that increases your heart rate by at least 10 beats above its baseline, you're going to do a lot better. You're going to do a lot better. All right. Now, questions. Please, as I see there's a lot of people on here, please bring up any types of questions, and I'm going to try to answer any types of questions you may have. Now, I can go over all the COPDs, but we don't have enough time as we're kind of spent a lot of time explaining emphysema itself. But I'm going to go over other diseases too, and I can bring up pulmonary. I have a pulmonary function test machine that I can also bring up here, and it's just in the other room. And I can bring up and show you, how a pulmonary function test works. So if you have any comments, questions, I am all ears and lungs. So go ahead and answer some questions. I'll be happy to answer some questions. Go right ahead, and whenever anybody's ready, want to ask a question, I'm right here. Remember, I am an expert in pulmonary rehabilitation. I am top 1 in the United States, but top 1%. So basically, there's a lot of good respiratory therapists. I'm very good at what I do for pulmonary rehab. Okay. So I'll wait for some questions. If there are no questions, I will stop and help some of my patients out. I have some time right now for anybody who wants to ask a question. Go right ahead and write in the comment section. I'll be happy to address those. While we're waiting for any questions, allergy season, spring's here. We're starting to see a lot more things bloom. Okay. What types of, I'm going to see if anybody knows, what type of filter can, oh my goodness, I got a book. God bless Dr. Doctor for his marvelous work in my life. I was diagnosed with herpes. What the heck is that? I was diagnosed with herpes since years back, and I was taking it in my medications. I wasn't satisfied if I needed. It's a spam thing. Deborah, we're going to have to block Deborah, it looks like, because that is nothing but spam. I don't know why people bring up things like that in here. It's just absolutely uncalled for. I have a question about what you said about pulse oximeter on the finger not being accurate because of the heart and brain gets the oxygen first. Okay, Patty, go right ahead. Ask a question. Go ahead, Patty. What's your question? So it's not necessarily the inaccuracy of a pulse oximeter. First, the pulse oximeter should be F. Why do you say that? I don't say that. That's in every. I don't say that. That's written in. I don't make things up. I go off of data. I go off of proven statistics. I go off of literature, things that have been proven with investigative review boards using peer review. So look, if air comes in, all right, Patty, if air comes in, let's just say oxygen. Let's say oxygen comes in. How in the world can it go straight to your finger? How can it go straight to your finger? I mean, it's not hard to understand. First line of sight is where? Patty. Patty, you got to try to answer quick if you can, please. What? If air comes in, you say look at a person's circulation, but it does not go to the brain before finger. You say look at a person's circulation. Well, of course I'm going to look at circulation and perfusion, because what if there's no blood running throughout the body? What if there's a shunt and there's preventing blood from running one side, or I'm having a blockage in one artery that's preventing blood from circulating through? And let's say I don't know that, I just know my arm's getting numb or something, or my side's getting numb, which is a big, big problem, okay? But if air comes into your lungs, it can't go straight to your finger. So the first line of sight, by looking at a circulatory system. Air comes in. Okay, it goes in, mind the disease, pretend the disease is not there. Let's use this side. Air comes in, goes into the alveoli, comes into the capillaries of the alveolar walls, where does it go next? Your heart is the first place it goes to. That's just normal. Okay, that's just what happens to every single living person. Okay, and animals too. So if it goes to your heart needs fuel, so it's going to pull some of that oxygen out. It's about 20% of that. The brain gets 30%. Okay, when oxygen is being transported, you breathe in, it doesn't go straight to your finger. Okay. So if I'm looking at circulation, is it possible that the person's hand is, let's say somebody's hand is very, very cold? Would that cause an inaccurate reading? Of course it will. Okay, if let's say I'm having an anxiety attack. You ever notice somebody has an anxiety attack? What are they doing? They're probably sitting still. They're sitting still and they're doing this. They don't know what's going on. I'm not sure. I think I'm having a heart attack right now. They're like that. The brain, they're not exercising. The brain's consuming everything they got. Okay? What is your pulse ox reading? It's probably reading extremely low, because any part from feet to hands is the extremities. Somebody goes into a cold batch of water. Let's just say the polar bear plunge, and I stay in that water for a very long time. I come out. Where would you see bluing, like bluish? My lips, probably around my gums, my nose, my fingers, my feet. First ones to go. First ones to be affected. Why is it blue there and not blue everywhere else? Unless I stay in for a very long time, of course, and of course I'm hypothermic, not hyperthermic, but hypothermic. Well, there's no brain on a red blood cell, so it relies on temperatures and pressures. Deborah, please stop. Deborah Gregory, please stop. These people actually need help. You know, most of them are, they're good people, they're smart, they're not going to listen to that garbage. And that is just, this is not about herpes. I'm not sure why you keep bringing this up, but this is obviously spam, so we're going to, unbelievable. Like, we're actually trying to help people here, and we do such a great job helping people, but then you have people that are just completely fake that just want to earn a buck, and I just hate that, How accurate do you consider a Fitbit for measuring overnight oxygen? A Fitbit? See, Marianne, it's a great, great, great question. If it is FDA approved, okay, FDA approved for measurements, not just approved for wearing, but approved for measurements. And it's stated that by a huge peer review that looked at the numbers from a lot of people, okay, and they seem to be exactly around this area. There's like, I hate to say deviations or something, but if it's FDA cleared, FDA approved for oxygen absorption and data, then that I would say is okay. But if it's not approved through the FDA for measuring oxygen during nighttime, okay, it might give you an inaccurate reading. So I don't know if Fitbit is FDA approved, but if it is, then yes, you could use it for that. But as far as somebody, for overnight oxygen, which I understand can be a little complex, you're going through a lot maybe, but if it's FDA approved, then it's a good one. If it's not FDA approved, unfortunately, it's not reproducible in its data and it's not accurate. I hate to say it like that, but that's true. So pulse oximeters rely on temperature. So when somebody programs a pulse oximeter, what type of data are they looking at? The variables, where things vary. What type of data are they looking at? What type of individual are they looking at for pulse oximetry? Are they only looking at diseased people, or are they just looking at oxygen itself? When they make a pulse oximeter, what types? It's a simple question. If I'm making something and I'm looking at, okay, oxygen, I'm going to program pulse oximeter to give me an alert when oxygen is below here, let's say 98 to 100 or 88 to 100. Who makes that up? The programmer. They're basing off of normal. They're not basing off of diseased. It even states that on the information. If you're not this information on this pulse, if you read the manual on it, it's basing it off of normal. It's not basing off of somebody's disease. Somebody is 90 years old with end-stage COPD. They're not basing it off of that. They're not basing it off of somebody who has Raynaud's disease or they have circulation problems. They have circulation perfusion problems. They're having their DLCO is very, very low, preventing gas exchange to go past the semi-permeable membrane. You know, they don't know you have a high temperature. They don't know you have a low temperature. So it literally states in the data of every pulse oximeter that is made, they should at least, okay? You can't have too much, you can't have a high temperature, you can't have a low temperature. Or else every number that comes up is inaccurate no matter what you may think, it's inaccurate. As soon as somebody has a high temperature, somebody has a low temperature. Inaccurate. Somebody has too much fingernail polish on their finger. Inaccurate. Too much ambient light, too much sunlight. Too much ambient light will cause an erroneous reading. So there's a lot of things that can cause an erroneous reading. It doesn't know that you're sick. It doesn't know that you have a high temperature or low temperature. It doesn't know anything like that because it's not programmed to do that. It's basing off of normals. It's basing off of normals. And I hate to use the word normal because I think there's no such thing. There's not one person in here is identical to somebody else. We could be male and female, sure, but there's no such thing as normal, I just, and what the heck is normal ever accomplished anyways? That's what I would say. So how accurate, I can't say because the data is not there. We have to look at data as scientists. We have to look at data, when we, for clinical, we have to look at data. We can talk all we want, but what really boils down to is the numbers, the reproducibility of those numbers. Okay, I hope that helps. So pulse oximetry assumes everything. This is nothing I made up. Okay, I'm a clinician. I'm a very advanced clinician. I'm also the director. So I teach other respiratory therapists of how to be a good pulmonary rehab therapist, or a good pulmonary rehab specialist therapist. Usually they're RTs, respiratory therapists. These are people that already have a bachelor's degree in their field and they have other certifications on top of that. So they're already educated on simple anatomy and physiology and different things, of course. But I hope that helps. Okay, you're welcome, Mary. You're very welcome. Any other questions? That's all the time we have for today. I'll see you guys back on Tuesday for a live. And Deborah, sorry, but you're out. I'm not going to have these people being succumbed to ridiculous, insanely ridiculous things. And on top of that, you can see it's a scam because it's a WhatsApp with a very extremely long number. Do not click on that. That is the most craziest thing in the world. Cure. Herpes, STD, cure. What a ridiculous thing to put on the comment section, Deborah. Like, absolutely ridiculous. And I'm pretty sure Deborah right now is probably not even a Deborah. You know that? All right, guys. That's all the time I have. Thank you very much.